Contra Hanson on Medical Effectiveness by Scott Alexander, APR 24, 2024. Introduction. Robin Hanson of Overcoming Bias more or less believes medicine doesn't work. This is a strong claim. It would be easy to round Hanson's position off to something weaker, like extra health care isn't valuable on the margin. This is how most people interpret the studies he cites. Still, I think his current actual position is that medicine doesn't work. For example, he writes, Europeans in 1600 likely prided themselves on the ways in which their modern medicine was superior to what primitives had to accept. But we today aren't so sure. 17th century medical theory was based on the four humors, and bloodletting was a common treatment. When we look back at those doctors, we think they may well have done more harm than good. When we look at our own medical practices, however, we tend to be confident we are in good hands, and that the money that goes to buying medical care, in 2020, it was 19.7% of our GDP, is well spent. Most of us know of a family member who credits their life to modern medicine. My own dad said this about his pacemaker, and I too am a regular customer. I'm vaccinated, boosted, and recently had surgery to fix a broken arm. We believe in medicine, and this faith has comforted us during the pandemic. But likewise, the patients of the 17th century, they could probably also have named a relative cured by bloodletting. Yet health outcomes are typically too random for the experience of one family to justify medical confidence. How do we know our belief is justified? This might seem like a silly question. In Europe of the 17th century, the average lifespan was in the low 30s. Now it's the low 80s. Isn't that difference due to medicine? In fact, the consensus is now that historical lifespan gains are better explained by nutrition, sanitation, and wealth. So let's turn to medical research. Every year, there are 1 million new medical journal articles suggesting positive benefits of specific medical treatments. That's something they didn't have in the 17th century. Unfortunately, we now know the medical literature to be plagued by serious biases, such as data dredging, p-hacking, selection, attrition, and publication biases. For example, in a recent attempt to replicate 53 findings from top cancer labs, 30 papers could not be replicated due to issues like vague protocols and uncooperative authors, and less than half of the others yielded results like the original findings. But surely modern science must have some reliable way to study the aggregate value of medicine. Yes, we do. The key is to keep a study so simple, pre-announced, and well-examined that there isn't much room for authors to cheat by data dredging, p-hacking, etc. Large trials where we randomly induce some people to consume more medicine overall and then track how their health differs from a control population, those are the key to reliable estimates. If trials are big and expensive enough, with lots of patients over many years, no one can possibly hide their results in a file drawer. After listing bigger studies that he interprets as showing no effects from medicine, he concludes, we spend 20% of GDP on medicine. Most people credit it for their long lives, and millions of medical journal articles seem to confirm its enormous value. Yet our lives are long for other reasons. Those articles often show huge biases, and when we look to our few best aggregate studies to assuage our doubts, they do no such thing. Or even more clearly, imagine someone claimed that casinos produce not just entertainment, but also money. I would reply that while some people have indeed walked away from casinos with more money than they arrived with, it is very rare for anyone to be able to reasonably expect this result. There may well be a few such people, but there are severe barriers to creating regular social practices wherein large groups of people can reasonably expect to make money from casinos. We have data suggesting such barriers exist, and we have reasonable theories of what could cause such barriers. Regarding medicine, the stuff doctors do, my claims are similar. His argument, there have been 3 big experimental studies of what happens when people get free or cut-price healthcare: Rand, Oregon, and Karnataka. All 3, according to him, find that people use more medicine but don't get any healthier. Therefore, medicine doesn't work. If it looks like medicine works, It's a combination of anecdotal reasoning, biased studies, and giving medicine credit for the positive effects of other good things, better nutrition, sanitation, etc. I've spent 15 years not responding to this argument because I worry it would be harsh and annoying to use my platform to beat up on one contrarian who nobody else listens to. But I recently learned Brian Kaplan also takes this seriously. Beating up on two contrarians who nobody else listens to is a great use of a platform. So I want to argue, medicine obviously has to work. Examined more closely, the three experiments Robin cites don't really support his thesis. There are other experiments which provide clearer evidence that medicine works. I'll follow Robin's lead in dismissing the entire medical literature, every RCT of every medication or treatment ever published, because it might have huge biases, and try to rely on other sources. Sega modern medicine improves survival rate. What do I mean by medicine obviously has to work? Age-adjusted mortality rate for most diseases has declined significantly over the past few decades. Robin doesn't want to credit medicine, arguing that this might be due to nutrition, sanitation, and wealth. But we can more clearly distinguish the effects of medicine by looking at the effects of secondary prevention, i.e., how someone does after they get a specific disease. For example, what percent of cancer patients die in 5 years? What percent of heart attack patients die within the first month after their heart attack? This is the kind of thing that depends a lot on how much medical care you get and is less affected by things like nutrition or sanitation. I'm more confident saying this about sanitation and wealth. You can imagine nutrition improving this. Maybe better nourished cancer patients are better able to fight their disease, but nutrition hasn't really improved over the past few decades in first world countries anyway. Here are 5-year survival rates for various cancers, 1970s versus 2000s. Figure, 5-year cancer survival rates in the USA. People with cancer are more likely to survive than 50 years ago. This is after you've already gotten the cancer, so it's hard to see how nutrition, sanitation, etc. could explain this. Some of these changes, especially prostate, are a result of earlier diagnosis, but others reflect genuinely better treatment. For example, studies have shown great results from the anti-leukemia drug imatinib and the anti-lymphoma drug rituximab. In Robin's model, these extraordinary studies would have to be bias or chance, and totally coincidentally at the same time, somehow better nutrition made leukemia patients, but not uterine cancer patients, twice as likely to survive. Might this be because people are getting cancer younger and therefore are better able to deal with it? I can't find great data on this. There's increasing cancer among younger people, but since people are living longer, we should also expect increasing cancer among older people, since there are more older people. Rather than try to figure out how to balance these effects, here's a graph showing similar survival improvements among childhood cancers in particular, where we wouldn't expect this to be a problem. Figure 5-year survival rates. Likewise, here is post-heart attack 30-day mortality rate over time. Figure post-heart attack 30-day mortality rate over time. The odds of death within 30 days of a heart attack have fallen from 20% in 1995 to 12.4% in 2015. Source. This is also no mystery. The improvement comes from increased use of basic drugs like ACIs, aspirin, and beta blockers, plus more advanced interventions like thrombolytics and angioplasties, plus logistical improvements like more heart attack patients being placed on specialized cardiac wards. Again, can we dismiss this because maybe heart attack victims are younger? The study this particular graph comes from says their patients were on average 2.7 years older at the end than the beginning. So here age effects seem to point in the opposite direction. Here's a graph showing the same decline if you break it up by under and over 65s, though I wish I could find something with smaller bins. Same data for stroke. Figure stroke. Source here. Note that these are age-adjusted data. In 2000, a stroke victim is only half as likely to die in the first 2 years after their illness as they were in 1980. Here we don't have to worry about age effects at all. The graph is already adjusted for age. You can see similar survival rate increases for other conditions like congestive heart failure. 5-year survival rate went from 29% to 60% since 1970. Multiple sclerosis, standardized mortality rate went from 3.1 to 0.7 since 1950. Type 1 diabetes, survival rate at 50 from about 40 to 80% since 1950, and nearly any other condition you look up. I'm harping on this because it's some sense the central example of medicine. You get some deadly disease like cancer, and you want to know if doctors can help you survive or not. All the evidence suggests medicine has gotten much better at this in the past 50 years. Robin's going to have a lot of hard-to-interpret studies about what happens to your cholesterol score or whatever after you change insurance, and we'll pick these apart. But to me, this seems like a much less central example of does medicine work than the fact that we're curing cancer and increasing heart attack survival rates. 3. Rand Health Insurance Experiment. This is considered the canonical study on the effect of health insurance. In the 1970s, Rand gave thousands of people one of 5 types of insurance, ranging from very bad, barely any coverage until a family reached a deductible of $1,000, i.e. $5,000 in today's dollars, to very good, all care was free. Then they waited 8 years. Then they checked whether the people on the good insurance ended up any healthier than the people on the bad insurance. The paper I found measured 5 questionnaire-based outcomes plus 5 objective physiological measures, for a total of 10 outcomes. Robin says he has a book where they discuss 23 to 30 outcomes, but I don't have that book, so I'm sticking with the paper. The 10 in the paper I read were Physical Functioning Questionnaire, Role Functioning Questionnaire, Mental Health Questionnaire, Social Life Questionnaire, Health Perceptions Questionnaire, Weight, Cholesterol, Vision, Blood Pressure. They found no effect of insurance on any of the questionnaires and modest positive effects on vision and blood pressure. How surprising is this? It seems moderately surprising that nobody improved on any of the questionnaires. These seem to measure overall health. Maybe they were bad measures? Maybe 10,000 mostly healthy people over 8 years doesn't provide enough power to detect health improvements on questionnaires? I'm not sure. It doesn't seem surprising to me that nobody improved on smoking, weight, or cholesterol. The 1970s didn't have any good anti-smoking medication. Even the nicotine patch wasn't invented until after this study was finished. Likewise, for weight loss, the 1970s were in the unfortunate interregnum between the fall of methamphetamine and the rise of Ozempic. There were some weak cholesterol medications back then, e.g. nicotinic acid, but they were rarely used, and doctors weren't even entirely convinced that cholesterol was bad. For all 3 of these things, the 1970s state-of-the-art was doctors saying, you should try to stop smoking and eat better. Rand found that the better insurances led to 1 to 2 more doctor visits per year. I don't think that 3 visits to a doctor saying you should try to stop smoking and eat better versus 4 visits to that doctor is going to affect very much. It's also not surprising that vision improved. The good insurances were more likely to cover glasses, and everyone knows that glasses help your vision. Even Robin admits this is a real effect. He just classifies it as more physics than medicine. Blood pressure is more debatable. The 1970s had some okay blood pressure medications, like the beta blockers, and doctors weren't afraid to use them. So it seems possible in theory that better medical care could lead to decreased blood pressure. Still, Robin is skeptical. He says that the improvement in blood pressure found during the study was p equals 0.03. In a study with 30 measures, one will be positive at 0.03 by coincidence. The version of the study he's reading has 30 measures. Mine has 5, 10, depending on how you count the questionnaire. On the other hand, this paper looks into the blood pressure result in more detail. It finds that plan effects on blood pressure were 3 times higher for hypertensives for non-hypertensives. That is, unlike statistical flukes, which we would expect to affect everyone equally, the effect was concentrated in the people we would expect doctors to treat. It also finds that plan effects are higher for poor people. Unlike statistical flukes, which would affect everyone equally, the effect was concentrated in the people we would expect insurance to help. And it finds pretty convincing intermediating factors. People with good insurance were 20 percentage points more likely to get hypertension treatment, p.001. So I think it's a stretch to attribute this one to random noise. This is the study author's conclusion as well. They calculate the benefit from this blood pressure improvement and find that if 1,000 50-year-old men at elevated risk were enrolled on a free rather than a cost-sharing plan, then we would anticipate that about 11 of them who would otherwise have died would be alive 5 years later. Still, they describe their study as having a negative result because these mortality reductions in and of themselves are not sufficient to justify free care for all adults. I assume they're working off of some kind of reasonable cost-effectiveness model for government spending here. Still, if I were a 50-year-old adult, I might be willing to personally spend a few $100 extra a year to increase my 5-year survival rate by 1%. Certainly, I don't think it's fair to describe this as Rand proves medicine doesn't work. Robin has a book with more information than I could get from the papers, so I feel bad contradicting him on this one. I'm more confident in my discussion of the next 2 experiments, which I think are clear enough that we can go back to this one later and apply what we've learned. A 4 Oregon Health Insurance Experiment. In 2008, Oregon had extra money and decided to expand Medicaid, a free insurance program for poor people. Many people applied for the free insurance. The state ran out of money, and they distributed the available Medicaid slots by lottery. This made the expansion a perfect setup for a randomized controlled trial on whether government-provided free insurance helps the poor. Scientists monitored the recipients for 2 years. Why not longer? I think at some point the insurance coverage stopped and found that the people with Medicaid did in fact use more medical care than the control group. For example, only 69% of the control group described themselves as getting all the medical care they needed, but 93% of the group with insurance did. People with the insurance used more of almost all categories of medication. Figure percentage with any RX medication. People who got the free insurance had less medical debt at the end of the study period. They described themselves on questionnaires as having better health, 55% versus 68% at least good, p.001, and were more likely to say their health had improved over the past few months, 71% versus 83%, p.001. They described having better mental health and less depression, 25-33% depressed, p=0.001. However, Robin notes that many of these subjective changes happened immediately, i.e. before they even had a chance to use their new insurance. This means they're more likely to represent mood affiliation, e.g., I have insurance now, so I'm optimistic about my health. There was no difference on objective health measures, including blood pressure, cholesterol, and HbA1c, a measure of blood sugar diabetes control. Why not? The authors do the math on diabetes. If you look at the graph above, you see that about 12.5% of controls versus 17.5% of experimentals took diabetes medications, p.05. Studies find that diabetes medications decrease HbA1c by about 1 percentage point. Normal HbA1c is about 5%, so this is a lot. If 5% of the insurance group took diabetes medications and decreased their HbA1c by 1 pp each, then the HbA1c of the experimental group would decline by 0.05 pp compared to the control group. Their 95% confidence interval of the difference was minus 0.1 plus 0.1 pp, which includes the predicted value. So when they say insurance didn't significantly change HbA1c, what they mean is the change in HbA1c is completely consistent with the consensus effect of anti-diabetic medications. Could the same be true of the other results, like hypertension? We find that the experimental group was 1.8 percentage points more likely to get a hypertension diagnosis, 0.7 percentage points more likely to get hypertension medications, and had 0.8 points lower blood pressure. But that all of these numbers were non-significant. If we take the non-significant numbers seriously, 0.7 pp, taking antihypertensives, caused an 0.8 point blood pressure drop in the full sample, meaning that antihypertensives caused a 100-point blood pressure drop in each user. This definitely isn't true. A 100-point blood pressure drop kills you, but it means that a plausible pro-medicine result like antihypertensives lowering blood pressure 10-point is well within the study's confidence interval. Maybe the anti-medicine position is that for some reason, good insurance doesn't lead to hypertension diagnosis or antihypertensive medication use. If I understand these numbers right, about 22% of Americans have blood pressure 140/90, the level at which doctors recommend medication. I expect the marginally insured poor people in this experiment to be less healthy than average, so let's say 25 to 30%. In the experiment, about 13.9% of the control group and 14.6% of the experimental group got antihypertension medication. Why so low? This study found that only about 60% of participants in the Oregon study who got the insurance even went to the doctor for non-emergency reasons. Subtract out the ones who refuse to take antihypertensives, or who have too many side effects, or whose doctors let this fall through the cracks, and I think the 13–15% numbers make sense. This study found that insurance increased hypertension medication use by a central estimate of 0.7 pp, not significant, confidence interval -4.5 to 5.8. Let's take a convenient central estimate of our likely hypertension rate and say that 28% of our population should have gotten hypertension meds. That means the central estimate increased the percent of people who got recommended hypertension meds from 50% to 53%, and the 95% confidence interval includes up to 71%. So my assessment of the blood pressure results from this study is, at the beginning of the study, about 50% of people who should have been on hypertension meds were. The study had too low power to really figure out how this changed, but the central estimate is +3%, and the 95% CI rules out improvements beyond +21%. The study had too low power to figure out if hypertension meds worked, and basically could not rule out any level of effectiveness, even effectiveness so high that the meds would instantly kill you by lowering your blood pressure to 0. I don't think we can summarize this study as, we've proven medication doesn't work. V. Karnataka Health Insurance Experiment. Same story, different scenery. This one happened in India, 10,000 families. End result is, having measured A, 3 parameters, direct, indirect, total, for B, 3 ITT and 1 TOT effect for C, 82 specified outcomes over 2 surveys, only 4–6% of all estimated coefficients concerning health outcomes were significant after multiple testing adjustments. As Table A8 shows, 55 parameters, 8.38%, are significant if we do not adjust for multiple testing. We cannot reject the hypothesis that the distribution of p-values from these estimates is consistent with no differences, p equals 0.31. We also find no effect of access on our summary index of health outcomes, Table A6 and Table A7. In other words, they tested a lot of stuff. If you don't adjust for multiple comparisons, they got 55 significant results. Once you adjust, they got 3 significant results. They can't prove that getting 3 significant results is itself a significant result. Their study was only powered to detect effects of size 0.1 or greater. It's helpful to look at their table of measured outcomes, A7. This has some of the usual ones like blood pressure, but it also has things like doctor or nurse assisted with childbirth, gave birth in a hospital, had surgery, takes medicine for hypertension, told that they have diabetes, told that they have cancer. and these were among the majority of their outcomes where the study found no effect. These don't cast doubt on the effectiveness of medical treatment. They just look like a study where the intervention didn't affect the amount of medical care people got very much. This was the author's conclusion too. In fact, they were unable to find a direct effect of giving people free insurance on those people using insurance at all in the 3.5-year study period. They had to rescue this with spillover effects, i.e. the effect of one person getting insurance in a village on other people in order to even claim that the insurance increased healthcare utilization. Why couldn't they find an effect of giving people insurance on those people using insurance? Insurance is very new in India. These people weren't really familiar with it, and in many cases their doctors and hospitals weren't very familiar with it. In a few cases, it didn't even seem like the insurance companies fully understood their product. Many households had difficulty using insurance to pay for healthcare. On average, across treatment arms, access to insurance increased by 3.34 pp annually, the number of households who tried to use their insurance card by 18 months but were unable to do so, from a base of 2.68% in the control group 12. Our TOT estimates suggest that insurance enrollment increased failed use by 4.02 pp off a base of 3% annually. This excess failure rate is 50.50% of the successful utilization ITT effect. Lack of knowledge about the purpose of insurance and how to use insurance seem likely explanations for the failure rate. Because insurance is a relatively new product, hospitals and beneficiaries may not know how to use it. Rajasekar, Berg, 2011, Nandi, Dasgupta et al., 2016. In our midline and endline surveys, we asked why households did not try to use their insurance card to pay for care and why they were unable to use the card even when they tried. Table A5. Frequent reasons given for not using the card were not knowing that the card could be used for insurance, 15% at 18 months, 20% at 3.5 years, forgetting the card at home, 13% at 18 months, not knowing how or where to use the card, 29% and 30% at 3.5 years. Besides these beneficiary-side problems, there were also supply-side problems. Of people that tried to use the card, 55% and 69% said that the doctor did not accept the card at 18 months and 3.5 years, and 12% said that the insurance company did not accept the card, i.e., did not approve use at 3.5 years. These should be interpreted with caution because we do not know if doctors correctly did not approve the card because a service was truly not covered or incorrectly did so. This finding suggests that demand-side education and supply-side logistics may be important for raising utilization of and thus demand for insurance in India and similarly situated countries. I don't want to over-update on this. They did eventually manage to find a medium effect of free insurance on insurance use when counting the spillover effects. I think the main problem with this study is the same as all the other studies. Its confidence intervals are wide enough to include medicine working amazingly well, better than anyone claims it works in real life. This is what the authors think too. Care should be taken in interpreting the insignificant health effects observed. Perhaps the effect of hospital care on measured outcomes is too small to translate into health improvements that we have power to detect despite our substantial sample size. Das, Hammer et al., 2008. Moreover, confidence intervals reported in Table A6 and Table A7 suggest that medically significant effects for many outcomes cannot be ruled out. 6. Summary of Robbins' 3 insurance studies. If it helps, think of these insurance studies as a sort of funnel. Figure funnel. In order for more insurance to result in better health on some measurable parameter, e.g. lower blood pressure, you need a chain of 4 things. First, you need the better insurance to result in more doctor's visits. Second, you need the doctor's visits to result in more diagnoses, e.g. of high blood pressure. Third, you need the diagnoses to result in more treatment, blood pressure medication. Fourth, you need the treatment to work, actually lower blood pressure. Each step lowers our ability to detect a signal. That is, going to the doctor doesn't, with 100% efficacy, result in more diagnoses. Some doctors will miss some diagnoses. That will introduce noise and lower our power statistical significance. You can imagine doing a whole paper on whether increasing doctors' visits increases hypertension diagnoses. That paper would have a p-value greater than 0/Bayes factor of less than infinity. So even assuming that better insurance really does improve health, each step we go down the chain decreases our ability to detect that. In fact, in these 3 studies, we find drop-offs below statistical significance scattered basically randomly throughout this chain. In some parts of the Karnataka study, we lose statistical significance at step 1. The better insurance didn't necessarily result in more medical utilization. For example, it didn't cause people to be significantly more likely to give birth in a hospital or get surgery. In the hypertension outcomes of the Oregon study, we lose statistical significance at step 2. The better insurance led to significantly more doctors' visits, but this didn't result in significantly more hypertension diagnoses. It only resulted in non-significantly more. I don't think we see any clear examples of losing significance at step 3, but you could sort of think of the smoking outcomes of the RAND study this way. The RAND participants with better insurance saw the doctor more. Probably the doctor noticed they were smoking and diagnosed them with this, insofar as tobacco use was a formal diagnosis at all in 1974. But there were no good anti-smoking treatments in the 1970s, so the doctor didn't prescribe anything. In the diabetes outcome of the Oregon study, we lose statistical significance at step 4. Diabetics with better health insurance were significantly more likely to see the doctor, significantly more likely to get diagnosed, and significantly more likely to get placed on medication, but only had non-significantly better health. Why? Probably because, as mentioned before, if diabetes medication worked as well as studies say it does, the study wouldn't have enough power to detect its effects. Robin's argument that medicine doesn't work assumes that the only possible failure is at step 4, and that the failure must be a true failure rather than one of statistical significance. But in fact, there are failures at every step, although I kind of have to stretch it for step 3, and the authors of the papers tell us explicitly that these are most likely failures of statistical power. This helps us think about a remaining question: why did these 3 studies get such different results? In the Oregon study, better insurance caused higher ratings of self-reported health, but in the RAND and Karnataka studies, it didn't. In the Oregon study, better insurance caused less depression, but in the RAND and Karnataka studies, it didn't. In the RAND study, better insurance caused increased use of antihypertensive medication, but in the Oregon and Karnataka studies, it didn't. In the RAND study, better insurance caused lower blood pressure, but in the Oregon and Karnataka studies, it didn't. In the Oregon study, better insurance caused more use of anti-diabetic drugs, but in the Karnataka study, it didn't. RAND didn't measure this. I think Robin attributes these differences to noise, i.e. the results being fake in the first place. He writes, "A muddled appearance of differing studies showing differing effects is to be expected. After all, even if medicine has little effect, random statistical error and biases toward presenting and publishing expected results will ensure that many published studies suggest positive medical benefits." I think this is implausible. Many of these effects are large and replicable. For example, the Oregon self-rating effects are p0.0001 on each of 4 different assessment methods, yet these are absolutely null in the other 2 studies. The RAND blood pressure results are p0.03, but match our expectations about subgroups, highest in the poor and sick, and accompanied by a p.01 finding that insurance results in more hypertension medication, which was absent in the Oregon study. The anti-diabetic drug result in Oregon was p equals 0.008. Can we explain these through differences in the studies? I think Robin's analysis here is actually pretty good. expanding it slightly. Rand was a normal cross-section of Americans. Oregon was poor and unhealthy Americans. Karnataka was poor Indians who didn't know how to use insurance, and they only got hospital care, whereas the other two studies included primary care. We find that Karnataka didn't result in as many utilization increases as the other two studies because it was only hospital care, which is unlikely to be involved in managing chronic problems like hypertension, and the recipients barely used the improved insurance. We find that Oregon had increased self-reported health because these were poor and unhealthy people who were very excited to get the new insurance. Robin points out that 2/3 of the improvement came immediately after getting the insurance, before they had time to use it, so this suggests a placebo effect. Maybe these poor, unhealthy people were more excited about getting free insurance than the comparatively well-off people in Rand or the insurance-naive people in Karnataka. But we can't dismiss the Oregon mental health findings as easily. Many of them came from depression screening questionnaires that ask pretty specific questions about sleep and suicidal thoughts over the past few weeks. I think these findings are plausibly real, especially given the strong effects of insurance on mental health medication use. See first graph in section 4 above. If so, differences from Rand and Karnataka would be easy to explain. 1970s Americans and rural Indians mostly don't have mental health problems, or at least don't think of them in those terms, whereas 2008 Americans do. In 2008 America, depression is common and easy to measure. Also, antidepressants have very large effect sizes. You may have heard they have small effect sizes, but that's after you subtract the placebo effect. Before you subtract placebo effect, they're extremely effective. And this study isn't controlling for placebo. So this is exactly the sort of area where you'd expect to see an effect. I won't say for sure it's real, but nothing about the studies makes me think it isn't. That just leaves the diastolic blood pressure effect in Rand. Remember our funnel again. The difference between Rand and Oregon doesn't start in step 4. Does the drug work? It starts in steps 2 to 3. Did more medical visits result in more medication? In Rand, we found that better insurance increased the percent of hypertensives on appropriate medication by 20 percentage points. In Oregon, we found that it increased it by about 2 percentage points, but with the confidence interval including 20. So my guess is that the middle-class people in Rand were a bit more likely to go for preventative medicine than the poorer people in Oregon, and that if we ran both experiments 1,000,000 times, we would get something like 5 to 10 pp out of Oregon and 15 to 20 pp out of Rand. And that's enough to give us the statistical power to detect an effect in Rand, but not Oregon. I can't prove this is true because of the statistical power issues. It just seems like a reasonable explanation for the discrepancy. One more point. Because of statistical power issues and multiple hypothesis testing, there are a lot of cases here where we can't say anything either way. These might be places where an effect seems plausible, but we can't prove it, or where we find an effect but can't prove that it isn't a result of multiple hypothesis testing. Here, we should go back to the statistical basics and remember that this means more or less nothing. We shouldn't update our priors. Part of how Robin makes his counterintuitive argument against healthcare is to say that all of these studies found null effects, so now we have to believe medicine is fake. I think instead, we should look at the arguments in section 2 above, start with a strong prior on medicine being real, and then, confronted with studies that sometimes can't find anything for sure either way, continue having that prior. The other more positive studies. Since Robin posted the early versions of his argument, there's been a newer, bigger, RCT-like study on the effects of medicine. Obamacare originally mandated that everyone get health insurance and punished non-compliance with a fine. In 2017, the IRS fined 4.5 million people for not having insurance. It originally planned to send these people a letter saying, Obamacare mandates you to have insurance, you're getting fined for failing to comply. please buy insurance through such and such a website. But it ran out of budget after sending 3.9 million letters to a randomly selected subset of the insurance lists. The letter must have been at least a little convincing, because the 3.9 million recipients were 1.3 percentage points more likely to get insurance compared to the 0.6 million non-recipients. So the whole event turned out as a sort of randomized trial of telling people to get insurance. Golden, Lurie, and McCubbin followed up on the results. Because this study was so big compared to the others, 4.5 million participants compared to a 5-digit number for Rand, Oregon, and Karnataka, they were able to measure mortality directly. They found that the rate of mortality among previously uninsured 45 to 64-year-olds was lower in the treatment group than in the control by approximately 0.06 percentage points, or one fewer death for every 1,648 individuals in this population who were sent a letter. We found no evidence that the intervention reduced mortality among children or younger adults over our sample period. Using treatment group assignment as an instrument for coverage, we estimate that the average per-month effect of the coverage induced by the intervention on 2-year mortality was approximately 9.17 percentage points. We caution, however, that the magnitude of the mortality eked is imprecisely estimated. Our confidence interval is consistent with both moderate and large ekes of coverage on mortality. At the same time, our estimated confidence interval is sufficiently precise to rule out per-month ekes smaller in magnitude than -0.03 percentage points, including the estimate from the OLS regression of mortality on coverage across individuals. This result was p equals 0.01 and robust to various checks. Robin's response. A 2019 U.S. tax notification experiment did maybe see an effect. When 0.6 of 4.5 million eligible households were randomly not sent a letter warning of tax penalties, the households warned were 1.1% more likely to buy insurance and 0.06% less likely to die over the next 2 years. Now, that last death result was only significant at the 1% level, which is marginal, so there's a decent chance this study is just noise. Come on. Thousands of clinical RCTs show that medicine has an effect. Robin wants to ignore these in favor of insurance experiments that are underpowered to find effects even when they're there. Then, when someone finally does an insurance experiment big and powerful enough to find effects, and it finds the same thing as all the thousands of clinical RCTs, p equals 0.01, Robin says maybe we should dismiss it, because p.01 findings are sometimes just noise. Here are some other quasi-experimental studies, A. Goodman-Bacon. Sommers, Biker, and Epstein finds that when some states expanded Medicaid after Obamacare, mortality rate in those states, but not comparison states, went down, p equals 0.001. Note that Biker was one of the main people behind the Oregon experiment. Sommers, Long, and Biker, same story. After Romneycare, mortality in Massachusetts went down compared to comparison states, p equal 0.003. Increased Medicaid availability for children was associated with lower child mortality. They don't give p-values, but some of the effects noted seem large. See more discussion on this thread. Final thoughts. The insurance literature doesn't do a great job in establishing one way or the other whether extra health insurance has detectable health effects on a population. Gun to my head, I'd say it leans towards showing positive effects. But if Robin wants to fight me on this, I can't 100% prove him wrong. But it's far less tenable to say, as Robin does, that these studies show medicine doesn't work. These studies are many steps away from showing that. First, as discussed above, it's unclear whether insurance studies themselves should be described as having positive or negative results. The best and biggest, like Lurie and Golden, show detectable and robust effects on mortality. Second, when insurance studies fail to show certain effects, they're practically always underpowered to say anything about the effects of medication. Often they can't even find that the better insured subjects use more medication than the less insured subjects, e.g., all negative RAND outcomes, all organ outcomes except diabetes, everything in Karnataka. When they can detect that better insured subjects use more medication, they can often precisely quantify whether their study has enough power to test the effect of medication, and explicitly find that it cannot. I can't think of a single one of the experiments Robin cites that finds an increased amount of medication in the experimental group, a power high enough to find medication effects, and a lack of medication effects. So these studies shouldn't be used to make any claims about medication effectiveness. Third, even if we were to unwisely try to use these studies to assess medication effectiveness, they only measure marginal cases. For example, in the Oregon study, the insured group used about 33% more healthcare than the insured group. E.g., the uninsured people had a hospital admission rate per 6 months of 20%, compared to the insured group's 27%. The uninsured group took about 1.8 medications daily, compared to the insured group's 2.4. Presumably, everyone is going to the hospital for very serious cases, e.g. heart attack, and the better insured people are just going for some marginal, extra, less serious things. Even if we could prove with certainty that the insured group's extra medication wasn't benefiting them at all, this doesn't say anything about the core 2/3 of medical care that people would get even if they weren't insured. Robin sometimes talks about how it's hard to distinguish core versus extra care, and I'm not sure how this works on paper, but in practice, the poorer patients I talk to seem to be able to distinguish it very well. Lots of them will go to the hospital for real emergencies, but start worrying about money for anything less. Fourth, we have strong direct evidence that medicine works, both in the form of randomized controlled trials and in the form of increasing survival rates after the diagnoses of many severe diseases. And this isn't just the diseases being diagnosed better and earlier, see for example here, or the patients getting the diseases younger, see the age-adjusted rates above. Even in the counterfactual, where we had unambiguous, well-powered, non-marginal insurance studies suggesting that medication didn't work, we should at most be confused by these conflicting sources. Most likely, that confusion would end in us setting the insurance studies aside as suffering from the usual set of inexplicable social science confounders, given that they contradict stronger and more direct clinical evidence. I think if Robin wants to do something with these insurance study results, he should follow other economists, including the study authors, and argue about whether the marginal unit of insurance is cost-effective, not about whether medication works at all. Response to Scott Alexander on Medical Effectiveness by Robin Hanson, April 27, 2024. Scott Alexander on Wednesday. I've spent 15 years not responding to Hanson's medicine argument because I worry it would be harsh and annoying to use my platform to beat up on one contrarian who nobody else listens to. But I recently learned Brian Kaplan also takes this seriously. Beating up on two contrarians who nobody else listens to is a great use of a platform. What claim of mine does he dispute? Robin Hanson of Overcoming Bias more or less believes medicine doesn't work. This is a strong claim. It would be easy to round Hanson's position off to something weaker, like extra health care isn't valuable on the margin. This is how most people interpret the studies he cites. Still, I think his current actual position is that medicine doesn't work. Scott then quotes 500 words from a 2022 post of mine, none of which have me saying all medicine is useless on all margins. Even so, he repeats this claim several times in his post. Now, I agree that the analogies I chose in the two places he quotes me, to casinos and to old medicine, were not to cases where there's clearly much difference between marginal and average effects. But analogies don't have to be the same in all features to be useful. Those analogy choices may have misled Scott. If so, I'm sorry, but I think I've been clear elsewhere, such as in our 2016 book, The Elephant in the Brain. Our ancestors had reasons to value medicine apart from its therapeutic benefits. But medicine today is different in one crucial regard. It's often very effective. Vaccines prevent dozens of deadly diseases. Emergency medicine routinely saves people from situations that would have killed them in the past. Obstetricians and advanced neonatal care save countless infants and mothers from the otherwise dangerous activity of childbirth. The list goes on. We will now look to see if people today consume too much medicine. We're going to step back and examine the aggregate relationship between medicine and health. We're also going to restrict our investigation to marginal medical spending. It's not a question of whether some medicine is better than no medicine. It almost certainly is. But whether, say, $7,000 per year of medicine is better for our health than $5,000 per year, given the treatment options available to us in developed countries. The medicine consumed in high-spending regions, but not consumed in low-spending regions, the research is fairly consistent in showing that the extra medicine doesn't help. Still, these are just correlational studies, leaving open the possibility that some hidden factors are influencing the outcomes. To really make a strong case, then, we need to turn to the scientific gold standard, the randomized controlled study. There's also my 2007 article, Cut Medicine in Half, where I say, in the aggregate, variations in medical spending usually show no statistically significant medical effect on health. The tiny effect of medicine found in large studies is in striking contrast to the large apparent effects we find even in small studies of other influences. Obviously, if I thought medicine was useless at all margins, I'd have said to cut it all, not just cut it in half. Scott's refutation of me focuses on A, specific evidence suggesting specific treatments help, and B, aggregate randomized experiments. On A, specific treatments, he considers cancer and heart attacks. We can more clearly distinguish the effects of medicine by looking at, for example, what % of cancer patients die in 5 years. People with cancer are more likely to survive than 50 years ago. Some of these changes, especially prostate, are a result of earlier diagnosis. Here's a graph showing similar survival improvements among childhood cancers in particular, where we wouldn't expect this to be a problem. Odds of death within 30 days of a heart attack have fallen from 20% in 1995 to 12.4% in 2015. Can we dismiss this because maybe heart attack victims are younger? The study this particular graph comes from says their patients were on average 2.7 years older at the end than the beginning. First, my claim of a near-zero marginal health gain from more medicine on average is consistent with some particular kinds of medicine having a positive marginal gains. We name some plausible candidates in our book. Cancer and heart attacks could also be among them, or maybe just childhood cancer. Second, to be relevant to my claim, these treatments need to be of the sort that many people get, but many others do not. I'm willing to presume that cancer and heart attack treatment fall into this category, but Scott doesn't show this. Third, Scott is well aware that many others attribute much of these changes to the population getting generally healthier over time, and thus better able at each age to deal with all disease, and also to earlier screening, which catches more cases that would never get very bad. He judges, although some of this is confounded by improved screening, this is unlikely to explain more than about 20 to 50% of the effect. The remainder is probably a real improvement in treatment. But he seems well aware that many other specialists judge differently here. On B, randomized experiments, Scott considers the 4 that I had mentioned. In a late 1970s Rand health insurance experiment on 7,700 people over 3 to 5 years, those who randomly consumed 30 to 40% more medicine were no healthier. In a 2008 Oregon health insurance experiment, where for 2 years 8,700 poor folk out of 35,200 eligible were randomly given Medicaid. This raised self-reported health, but mostly before they got any treatment. It cut medical debt. In a 2021 Karnataka hospital insurance experiment, half of 52,300 people were randomly given free or cheap access hospital insurance for 3.5 years, which increased their hospital insurance take-up from 60% to 79%. Again, no significant health difference. In a 2019 U.S. taxpayer experiment, zero point 0.6 of 4.5 million were not sent a letter saying they faced a tax penalty for lacking insurance. Over the next 2 years, those sent a letter got 0.23 more months of insurance. The headline result given is that the 45 to 64-year-olds among them also had 0.06% lower mortality at 1% significance. Scott sees the first 3 as too underpowered to find interesting results. He found the results of RAND moderately surprising, but thinks it's a stretch to attribute peak equals 0.03 blood pressure result to random noise, even if it's the only result out of 30 at p.5. Scott calls Karnataka a study where the intervention didn't affect the amount of medical care people got very much, as they were unable to find a direct effect of giving people free insurance on those people using insurance at all in the 3.5-year study period. But I see this study as reporting big utilization effects. The average annual insurance utilization rate at 18 months, 3.5 years, is 13.46%, 2.56% in the free insurance arms versus 7.72%, 0.64% in the control arm. On average, this effect amounts to a 74.35%, 400% increase in insurance utilization at 18 months, 3.5 years. And this seems to me a non-trivial constraint on medical effectiveness. We cannot rule out clinically significant health effects, on average equal to 11%, 8.8% of the standard deviation for each health outcome in ITT analyses. They can rule out larger effects. Regarding U.S. taxpayer, until now I've written only one short paragraph on it, which ended calling 1% significance marginal, so there's a decent chance this study is just noise. Scott was irate at that. Come on. Thousands of clinical RCTs show that medicine has an effect. Robin wants to ignore these in favor of insurance experiments that are underpowered to find effects even when they're there. Then when someone finally does an insurance experiment big and powerful enough to find effects, and it finds the same thing as all the thousands of clinical RCTs, p equals 0.01, Robin says maybe we should dismiss it because p equals 0.1 findings are sometimes just noise. Here are some other quasi-experimental studies. As Scott knows, we have a huge problem of selective publication and specification search, p-hacking, especially in medicine, which is why I'm suspicious of the few quasi-experimental studies that find big health gains from medicine. I know that typical regressions of health on medicine find no effect, and also that medical errors, and prescription drugs cause huge numbers of deaths. Thus, I focus on our few best studies, randomized experiments. Over the last day, I've gone over that U.S. taxpayer experiment more carefully. The authors claim that their headline result of 0.06% lower mortality among 45 to 64-year-olds at 1% significance is robust to the choice of that age range. Online Appendix Table AXV shows that the presence, but not the magnitude, of the mortality effect is reasonably robust to adopting alternative age cutoffs for defining the sample. But that table seems to me to show no such thing. Compared to the 0.01 neurosignificance for their preferred age range, the other 5 age range estimates tested there have significance 0.044, 0.052, 0.069, 0.252, 0.319. Clearly, I was right to suspect their 1% result to be marginal. Projecting this 0.06% lower mortality, given 0.23 more months of insurance to all 24 months, we'd get a 30% mortality cut for the fully insured compared to the fully uninsured for this age range, with other ages getting no cut, which seems a high estimate to me. But while that is an ordinary least squares OLS estimate, the paper prefers a 7x larger instrumental variables IV estimate. These are often problematic in economics due to specification searches and false specification assumptions. Their IV estimate is each month of insurance coverage induced by the intervention during the 2-year outcome period reduced mortality by approximately 10.1%, which is crazy huge. As 10.1%, 24 equals 112.9, the same size effect for each of the 24 months in this period implies 13x lower mortality for the fully insured over fully uninsured. which is surely an effect we'd have noticed in health on medicine regressions. They agree this is implausibly large and are embarrassed that their 95% confidence OLS and IV intervals don't even overlap. But they note that the low end of their 95% confidence range is only 2.2%, which only implies the fully insured have 41% lower mortality than the fully uninsured for this age range. Now, while their OLS estimate of the effect of treatment on mortality is only significant at the 1% level, and that exaggerated by selection bias, their OLS estimate of the effect of more insurance on mortality looks much stronger. At least if we could believe their Table 4, which gives an estimate there of minus 0.26 and a standard error 0.001 for a crazy huge ratio of 26. But as they never even discuss this crazy huge significance in the text, I have to suspect that this is just a table typo. W. The Karnataka paper mentions other randomized trials that I haven't looked at, but hope to soon. This specific result is consistent with results from all other RCTs of health insurance conducted in lower-income countries. Haushofer et al., 2020, King et al., 2009, Levine, Polemini, and Ramage, 2016, Thornton et al., 2010. To summarize, contra Scott, I only claim that the aggregate health effect of marginal medicine is typically small and of low economic value relative to costs, but not zero. While many studies claim to show otherwise for specific treatments, those tend to be quite biased, pushing me to focus on our least bias-able studies, randomized trials of aggregate medicine. I say that they still consistently fail to find clear effects. Yes, this is in part because these studies aren't larger. But the first experiment, RAND, was funded in part because many expected it to show that more medicine caused much more health, which would help them argue for giving everyone free medicine. That is why the main book on it was called Free for All. Not seeing results was in fact surprising to its sponsors, and these null results continue to be surprising to most everyone who learns of them. Okay, I looked at those 4 further randomized experiments. In Kenya, 789 workers were split into 3 groups: free paid cash of premium, no help. Free folk had lower cortisol and stress levels. In Nicaragua, 608 people were randomly assigned different health insurance prices. 20% took insurance, and a year later they saw no change in medical utilization. In Cambodia, 5,000 households were randomly assigned different health insurance prices. Those given lower prices were less likely to take on new debt due to a bad health shock. No change was seen in how much medical care people sought. In Mexico, for 534,500 people living in 148 geographic areas in random matched pairs, one of each pair was given more resources to upgrade facilities, and people there were encouraged to enroll in insurance. After 10 months, barely 5% significant effects on catastrophic spending overall and for poor, and on health spending of poor. No effects on overall spending health outcomes or medical utilization. So not seeing any effects on medical utilization, these studies can't speak to the effect of medicine on health. Response to Hanson on Healthcare by Scott Alexander. APR 30th, 2024. Robin Hanson replied here to my original post, challenging him on healthcare here. On strawmanning, Robin thinks I'm strawmanning him. He says, Scott then quotes 500 words from a 2022 post of mine, none of which have me saying all medicine is useless on all margins. Even so, he repeats this claim several times in his post. If Scott had doubts, he could have asked me, or consulted our 2016 book, The Elephant in the Brain, 52K copies sold. I'm sure he knows of it. Our ancestors had reasons to value medicine apart from its therapeutic benefits. But medicine today is different in one crucial regard. It's often very effective. Vaccines prevent dozens of deadly diseases. Emergency medicine routinely saves people from situations that would have killed them in the past. Obstetricians and advanced neonatal care save countless infants and mothers from the otherwise dangerous activity of childbirth. The list goes on. We will now look to see if people today consume too much medicine. We're going to step back and examine the aggregate relationship between medicine and health. We're also going to restrict our investigation to marginal medical spending. It's not a question of whether some medicine is better than no medicine. It almost certainly is. But whether, say, $7,000 per year of medicine is better for our health than $5,000 per year, given the treatment options available to us in developed countries. Ray, the medicine consumed in high-spending regions, but not consumed in low-spending regions, the research is fairly consistent in showing that the extra medicine doesn't help. Still, these are just correlational studies, leaving open the possibility that some hidden factors are influencing the outcomes. To really make a strong case, then, we need to turn to the scientific gold standard, the randomized controlled study. We seem pretty clear to me there. There's also my 2007 article, Cut Medicine in Half, where I say, in the aggregate, variations in medical spending usually show no statistically significant medical effect on health. The tiny effect of medicine found in large studies is in striking contrast to the large apparent effects we find even in small studies of other influences. Obviously, if I thought medicine was useless at all margins, I'd have said to cut it all, not just cut it in half. I acknowledge he's the expert on his own opinion, so I guess I must be misrepresenting him, and I apologize. But I can't figure out how these claims fit together coherently with what he's said in the past. So I'll lay out my thoughts on why that is, and he can decide if this is worth another post where he clarifies his position. The marginal unit of healthcare doesn't come clearly marked. If we want to cut the marginal unit of healthcare, for example, following Robin's recommendation to cut healthcare in half, we need to cut specific things. If you would otherwise get 10 treatments in a year, you need to cut out 5 if you want to have healthcare like Robin suggests. Which 5? You could make the decision centrally. The medical establishment decides some interventions are less valuable than others, and insurance stops covering those, or in a decentralized free market way. Customers get less insurance, increasing the cost of medical care and causing them to make harder trade-offs about when to get it. But somebody has to make this decision at some point. On what basis do they make it? One possible reasonable position might be, obviously the cancer stuff and the antibiotics are important, so definitely keep those. Find stuff which seems frivolous, and then cut that. My impression is that Robin has very clearly rejected this position. For example, from here. It is clearly not the case that marginal care contains mostly treatments that doctors know to be less useful and more frivolous, while the serious situations where doctors know medicine is very valuable are usually in common care. In fact, doctors do not seem to see a difference between common and marginal care. So if common care is much more useful on average than the useless on average marginal care, it must be because each patient somehow knows something that doctors cannot see about when he really needs to see a doctor. Now, how likely is that? We just don't know which treatments are useful versus bad. But don't we know, for example, that antibiotics are good? Robin again. But what about those miracles of modern medicine we have all heard so much about? Did not the introduction of antibiotics, for example, dramatically reduce death rates for key diseases? Well, not much, actually. Public health measures, sanitation, clean water, Robin again. If medicine for treating individuals is not quite the miracle we have heard, does public health make up the difference? Have not we all heard how the introduction of modern water and sewer systems greatly improved our ancestors' health? Well, a century ago, the U.S. cities with the most advanced water and sewer systems had higher death rates than the other cities. Also, we can look today at how the death rates of individual households correlates with the water sources and sewer mechanisms used by those households. Even in poor countries with high death rates, once we control for a few other variables like social status, we usually find that water and sewer parameters are unrelated to death rates. Well, we must live longer now for some reason, right? Yes, but the fact is that we just do not know why we now live so much longer. Robin seems more bullish on sanitation elsewhere, so maybe he's changed his mind. Like I said, I have trouble fitting all his statements into a coherent model. Okay, then how do we have medical care? In his Cato Unbound article, I interpret him as saying it didn't matter how you did it, because most any way to implement such a cut would likely give big gains. Am I strawmanning him again here? Doesn't he obviously think we should spend some time figuring out which medical treatments are good and effective? Cancer care? Vaccines? So we don't accidentally cut those? In a podcast, he mocked other economists who said that you needed to be really careful and work hard to figure out which parts of medicine were good so you could make sure to cut only the useless parts. I did a Cato Unbound forum about 10 years ago where my starting essay was Cut Medicine in Half, and a number of prominent health economists responded there. None of them disagreed with my basic factual claims about the correlation of health and medicine and other things, but still, many of them were reluctant to give up on many medicine. They said, well, yes, on average it doesn't help, but some of it must be useful, and we shouldn't cut anything until we figure out what the useful parts are. And I make the analogy of that with a monkey trap. In many parts of the world, there are monkeys that run around, and you might want to eat one. To do that, you need to trap one. And a common way to trap a monkey is you take a gourd, that is, a big container that's empty, and you put a nut on the inside of that gourd, and the monkey will reach into the gourd and put his fist around the nut and try to pull his hand out, because then mouth is too small to get his hand up, and he will not let go of that nut. Robin thinks it's a monkey trap to try to cut the bad parts of medicine, but not the good. This seems consistent with his claim that you can't distinguish good from marginal care, and with his claim that he's not sure antibiotics or public sanitation are good. It seems to me that if we were to cut medicine in half, figuring out which half to cut would be among the most consequential decisions in history. For example, if we foolishly tried to cut out all treatments that start with letters AM, then we would lose antibiotics, appendectomies, AIDS medications, etc. I would expect even small mistakes in this process to cause more deaths than 9/11, the Iraq War, or other things we think of as greatly consequential. But Robin doesn't seem to think this matters very much, and his antibiotics and public health comments make it sound like this is because he's not particularly sure that even the most respected forms of medicine work. This is the context in which I cited his casino quote, source, in the original article. Imagine someone claimed that casinos produce not just entertainment, but also money. I would reply that while some people have indeed walked away from casinos with more money than they arrived with, it is very rare for anyone to be able to reasonably expect this result. There may well be a few such people, but there are severe barriers to creating regular social practices wherein large groups of people can reasonably expect to make money from casinos. We have data suggesting such barriers exist, and we have reasonable theories of what could cause such barriers. Regarding medicine, the stuff doctors do, my claims are similar. In the context of everything else, I can't help but interpret this as suggesting that medical care is net neutral, or even, like casinos, net negative, and that just as there is no specific slot machine that you know will work at a casino, and you would do best avoiding all of them, so there's no one medical treatment that we know is positive in expectation, and cutting any of it would be fine. Maybe this is all straw manning. All of this is taken out of context, and the only place that Robin says his true opinion is in his book. But in that case, I feel like this is a pretty extreme failure of communication that's not entirely my fault. Also, other people seem to interpret it the same way I do. If I thought medical care was mostly effective and just needed to be trimmed around the margin, and my readers were posting that I thought medical care was useless, or that all health spending is wasteful, or that medicine is net neutral for health, I would be horrified and try to clear it up as quickly as possible. Somehow, in 15 years, this hasn't happened. I guess if I can get Robin to make this clarification, even if it turns out I'm totally wrong and misunderstanding everything he says, then maybe this post will have been worthwhile. So, in the interests of getting a clearer understanding, I'll pose Robin a trilemma. Either we can't distinguish between good and bad medical interventions, but the average intervention is net positive in expectation, in which case it seems like we should keep the amount of medicine we have now, since we assess each treatment equally and they're all net positive. Or we still can't distinguish between good and bad medical interventions, but the average intervention is, after you count the monetary cost, net neutral or negative in expectation, in which case one should be equally skeptical of everything, including antibiotics and cancer treatment, and I don't understand how saying this is a straw man. Or we can distinguish between good and bad medical interventions, and we should throw out the bad ones and keep the good ones. In which case, why does Robin keep saying the opposite? Why does he call this a monkey trap, etc.? And wouldn't it be better for Robin to frame his position as medicine generally works well, but there are some interventions that aren't evidence-based enough, which is the consensus medical position? If this is a false trichotomy, Robin should tell me how. Let's do near mode. Despite, maybe, disagreeing about healthcare, I have a huge amount of respect for Robin. He's developed or popularized many of the ideas that still shape my thinking. One of them is near mode versus far mode, his take on construal level theory. I find it helpful at times like this to try to go as near mode as possible. For example, in one of the papers I linked above, Robin writes, "Unfortunately, even if you believe everything that I have said, your behavior will probably not change much as a result. You will still spend nearly as much on medicine for yourself and your family, and spend much less effort on the more effective ways to increase lifespan. After all, your sick family would consider it the worst kind of betrayal if you did not do something and give them all the medicine that your doctor recommends." Hanson, 2002. Alas, the problem of the fear of death muddling our thinking is so much worse than we imagined. I interpret this as him saying that if you were smart, had the courage of your convictions, and weren't so obsessed with signaling, then you, the literal reader, would cut your individual healthcare expenses right now after learning about his theory. I, like many people, would like to spend less money on healthcare without my health being negatively affected in any way. The nearest way possible to approach this is to think about how Robin's theory suggests that I act. Here are some categories of health problem that I might one day have to think about. A heart attack or stroke, going to the hospital. Cancer, going to an oncologist, complying with their recommendations. A bacterial infection, e.g. pneumonia, sinusitis, meningitis, etc., going to a doctor, urgent care, ER, taking antibiotics if recommended. A chronic disease like type 2 diabetes, going to the doctor, following their recommendations about glycemic control, taking medicine if recommended. New onset unexplained but serious seeming symptoms, e.g. sudden intense abdominal pain or suddenly feeling very dizzy, getting checked out by a doctor or hospital. New onset unexplained but mild seeming symptoms, e.g. mild abdominal pain or suddenly feeling slightly dizzy, getting checked out by a doctor or hospital. Acting erratically, hallucinating, saying things that don't make sense, going to a psychiatrist or mental hospital. Feeling very depressed or anxious, so much so that it's hard to get through the day or do your usual work, going to a psychiatrist. A middle-aged person with a family history of cardiovascular problems who hasn't gotten a checkup in a while, going to a doctor, taking statins, ACIs, etc., if recommended. Just sort of feeling blah all the time, e.g. tired, joints ache, etc., going to the doctor and getting checked out. So my second question for Robin is, how do you recommend I proceed? Do I avoid going to the doctor for some specific subset of these categories, like 5 to 10? Are all the categories equal, such that I should flip a coin each time I get an illness, and only go to the doctors if the coin comes up heads? Get certain care in some categories, flip the coin for others? This isn't intended to be a rhetorical question. I'm hoping it clarifies what it means to cut the marginal unit of healthcare, what a reader who didn't have the fear of death muddling their thinking would do, and how much Robin believes we can distinguish between good and bad treatments. Actually, we can get even nearer. My wife and I recently took my 4-month-old son to the pediatrician. The pediatrician said he had a misshapen head and referred him to a head specialist for a second opinion. The specialist said, "Yup, looks pretty misshapen," and referred us to a helmet maker. The helmet maker said, "Yeah, definitely misshapen," and wants us to pay $300 for a helmet to correct it, so my son doesn't get stuck permanently looking like Frankenstein when he grows up. There are some studies of this intervention which are neither obviously wrong nor obviously unimpeachable. They say the helmet works, but not necessarily better than repositioning therapy. Our son refuses repositioning therapy, so for us it's the helmet or nothing. That helmet is probably our marginal healthcare expense, in the sense that it's less obviously important than the other two things we've used healthcare for this year: childbirth, a scare with our son's breathing. So, if we're trying to cut the marginal healthcare expense, should we skip the helmet? Maybe we should skip it. I never see any adults with obviously misshapen heads out there, and surely they didn't all get $300 helmets as kids. Maybe it's all a racket. For pictures of people with misshapen heads, see here: dead dove, do not eat. How would Robin recommend I make this decision, if not by consulting the studies? Should I just base it off the Rand experiment? Are we sure that there were any babies with misshapen heads in Rand at all? Did Rand even use has non-Frankenstein head shape as an endpoint? Should I still go off Rand? Or should I trust Johns Hopkins and all the specialists when they say this is good? This is as near as I can get. What now? Is Robin's advice just aimed at some hypothetical dumb person who constantly gets healthcare for stupid reasons and never considered stopping? Or should I personally try not to get healthcare in situations like this one? If I value my son looking like a normal human being when he grows up at, let's say, $30,000, then it seems like I should only need a 1% credence that this therapy works before I spend $300 on it. And surely my credence of something backed up by all available studies is higher than that. Is this Pascal's wager? But doesn't all medicine have those kinds of odds? What do I do? On cancer, heart attack, etc. survival rates, moving through more specific sections of his post. First, my claim of a near zero marginal health gain from more medicine on average is consistent with some particular kinds of medicine having a positive marginal gains. We name some plausible candidates in our book. Cancer and heart attacks could also be among them, or maybe just childhood cancer. I don't understand how this isn't the Cato economist position. Keep the good stuff that we know works and look for likely not to work forms of treatment around the edges that we can cut. I certainly have some guesses about forms of medicine that don't work. Most surgeries for back pain are in this category. Do they add up to half of all medicine? I'm not sure, but if Robin agrees that this is the discussion, we can compare our lists and try to figure it out. Second, to be relevant to my claim, these treatments need to be of the sort that many people get, but many others do not. I'm willing to presume that cancer and heart attack treatment fall into this category, but Scott doesn't show this. Again, if Robin's claim is that medicine is only useless on the margins, we're much closer to agreement. But I don't know how that meshes with saying that maybe antibiotics don't help, or that we can't possibly distinguish marginal from core, or that health spending is mostly signaling, as opposed to a mix of people correctly spending money on health because they know it's great and will help them, plus some extra from people not being scientists and not knowing which treatments are good or bad. Third, Scott is well aware that many others attribute much of these changes to the population getting generally healthier over time, and thus better able at each age to deal with all disease, and also to earlier screening, which catches cases that would never get very bad. He judges. Although some of this is confounded by improved screening, this is unlikely to explain more than about 20 to 50% of the effect. The remainder is probably a real improvement in treatment. But he seems well aware that many other specialists judge differently here. But the link is to a blog post where I examine this and find many studies showing, I think very clearly, that it really is medicine and not screening. Yes, other people think differently, but the link you're using is a post about why they're wrong. But also, why is Robin objecting to this? I thought he was admitting that cancer treatment is maybe potentially good. This is why I find this conversation so frustrating. Mention a medical treatment to Robin, even one of the good ones, like cancer or antibiotics, and he'll try to argue that maybe the evidence it works is being misinterpreted, and in fact, it's unclear how well it works. Then I say, he thinks this stuff might not work, and he accuses me of strawmanning him. I would have no objection if there were, in fact, some evidence that cancer treatment was useless, and he was trying to bring it to my attention. But all he's doing is linking my post showing that it's not true, plus the article I started my post with as an example of the false narrative I'm trying to correct. On insurance experiments, I don't see Hanson responding to my main point, which is that the insurance experiments show signs of having their power fail at random points in the causal chain, rather than showing anything about medicine. Just to rehash this for people who forgot. The Karnataka experiment couldn't show that insurance made people more likely to give birth in hospitals, or more likely to have a doctor tell them that their blood pressure was too high, or basically any outcome related to how much care they were getting, let alone whether that care worked. The Oregon experiment found people got more diabetes drugs, but not that they had less diabetes. However, if you do a power calculation based on the increase in diabetes drugs and the known effect of diabetes drugs, we find that the experiment wouldn't have detected it even if it was there. And the same is true of hypertension and most of the other things they measured. The RAND outcomes I found were mostly things that doctors had no medicine for in the 1970s when the study was conducted. For example, they measured the effect of healthcare on obesity, but there were no good obesity drugs in the 1970s. Instead, he discusses small quibbles with how I describe certain results. I'll go through these quibbles, but I want to make it clear I don't think they matter very much, and I would much rather talk about the main point. Going through the quibbles, Scott sees the first three as too underpowered to find interesting results. He found the results of RAND moderately surprising, but thinks it's a stretch to attribute p.03 blood pressure result to random noise, even if it's the only result out of 30 at p.05. I find it unfair to present this claim without presenting my reasoning, which is that there's a whole other paper, How Free Care Reduced Hypertension in the RAND Health Insurance Experiment, which does various sanity checks to this result, finds that it holds up, and finds related claims with lower p-values. Scott calls Karnataka a study where the intervention didn't affect the amount of medical care people got very much, as they were unable to find a direct effect of giving people free insurance on those people using insurance at all in the 3.5-year study period. But I see the study as reporting big utilization effects. The average annual insurance utilization rate at 18 months, 3.5 years, is 13.46% in the free insurance arms versus 7.72%, 0.64% in the control arm. On average, this effect amounts to a 74.35%, 400% increase in insurance utilization at 18 months, 3.5 years. I said in my original post that utilization rates increased when spillovers were taken into account, but did not directly increase for the insured individuals. He is quoting the first half of a section that then goes on to say, spillovers play an important role in boosting utilization. At 18 months and 3.5 years, ITT estimates of the direct effects of insurance access are not significant. So this was exactly what I said in my post, except that Robin takes out my explanation and quotes only half of the section, so that I look like a moron who didn't read the paper. This seems to me a non-trivial constraint on medical effectiveness. We cannot rule out clinically significant health effects, on average equal to 11%, 8.8% of the standard deviation for each health outcome in ITT analyses. They can rule out larger effects. Again, this isn't just about the effects of medicine. The outcomes Hanson is talking about include many things like giving birth in a hospital, or having surgery, or being told you have arthritis. If insurance can't improve the likelihood of these things, it's failing to connect with the medical system at all, not some kind of evidence that medicine doesn't work. On the Golden paper, now while their OLS estimate of the effect of treatment on mortality is only significant at the 1% level, and that exaggerated by selection bias, their OLS estimate of the effect of more insurance on mortality looks much stronger, at least if we could believe their Table 4, which gives an estimate there of -0.026 and a standard error 0.001 for a ratio of 26. But as they never even discuss this crazy huge significance in the text, I have to suspect that this is just a table typo. Other people have pointed this out, and I'm not sure what's going on here. Cremieux thinks all of Golden might be a Lindley's paradox situation, suggesting it isn't a real effect. And I'm trying to clear this up with him and figure out if he's right. I think my case is still strong if we stick with the lower treatment effect or ignore Golden entirely. As Scott knows, we have a huge problem of selective publication and specification search, p-hacking, especially in medicine, which is why I'm suspicious of the few quasi-experimental studies that find big health gains from medicine. In 2004, the International Committee of Medical Journal Editors released a statement saying they would no longer accept non-pre-registered studies that started after July 1, 2005. Since then, all studies have had to pre-specify their protocol, making p-hacking much harder. You can see the results on trial composition here. Figure 3 time trends. And on p-hacking levels here. Figure 4 density discontinuity tests at z equals 1.96 primary outcomes. Obviously, this doesn't mean that there's no possible way medical studies could ever be biased. But I worry that people act like studies can be p-hacked is some sort of secret knowledge that elevates them above domain experts. Medical evidence is processed by groups like NICE and the Cochrane collaboration that have been worrying about p-hacking since 2004, trying to factor its existence into their recommendations, and organizing pretty successful campaigns among journals and other stakeholders to minimize it. This doesn't mean everything is perfect, but I think we're beyond the level where you can say, what about p-hacking, and use it to throw out every clinical study in favor of 3 social science experiments that explicitly admit they don't have enough power to test these kinds of questions. I know that typical regressions of health on medicine find no effect, and also that medical errors in prescription drugs cause huge numbers of deaths. Thus, I focus on our few best studies, randomized experiments. The first link goes to a study that does not try to quantify the number of deaths from medical error. The second goes to a claim that prescription drugs are the 3rd leading cause of death. For the latter, I would recommend reading Medical Error is not the 3rd leading cause of death, and Medical Errors are the 3rd leading cause of death, and other statistics you should question. These numbers usually come from massively overcounting medical errors from studies not intended to quantify them, from calling any death that happens after a medical error a result of a medical error, and from ignoring the many more sober estimates of medical error fatality rate that have been published. This isn't to say that medical errors aren't real and serious, just that I don't think many people now continue to defend that particular claim. While many studies claim to show otherwise for specific treatments, those tend to be quite biased, pushing me to focus on our best studies, randomized trials of aggregate medicine. I say that they still consistently fail to find clear effects. I've tried to explain how thoroughly I disagree with this claim, but let me try one more time. Suppose we want to know something simple, like whether being shot with a gun can kill someone. One option is that we get trials where we shoot 1,000 people with guns, shoot another 1,000 people with placebo guns, blanks, and see how many in each group die. Maybe we could do this 100 times for every different type of gun. Maybe we'd even find that some guns, e.g. BB guns, don't kill people, and we could replicate that a dozen times. I believe this method would be very decisive. But maybe this would be biased. Maybe the only unbiased way to test this, for some reason, is to give 1,000 people a special voucher that they can use to buy guns and leave another 1,000 people as a control. Then we wait 2 years and see whether the voucher group gets convicted of murder more often than the control group. And maybe in fact we do this, and we find that there are 3 more convicted murderers in the voucher group, but this isn't statistically significant. Do we conclude that being shot with a gun can't kill you, or the marginal gun can't kill you? No. Among many other possible ways this could go wrong, we might find that only 3 extra people in the voucher group tried shooting someone. This exactly corresponds to our 3 extra deaths, consistent with a 100% death rate from being shot. But if you don't ask this question, and you just stop at, well, there were only 3 extra murders, which isn't statistically significant, then it looks like getting shot with a gun can't kill you. I don't understand why you would prefer the second form of study over the first, especially if you're going to summarize its results as guns aren't dangerous. The marginal gun isn't dangerous? Some guns are dangerous, but we can't tell which ones. Some guns are dangerous, we can tell which ones, and we should just focus on those. Maybe I'm still misunderstanding Robin. I look forward to him clarifying his position further. In case my own position isn't clear, I think lots of medicine is useless, and that most doctors would agree with this. We overorder tests when we don't need them. We do a lot of ineffective stuff to please patients, starting with antibiotics for viral illnesses, but sometimes going up to surgeries that have only placebo value, and we do lots of treatments that we know fail by 90% of the time, like certain kinds of rehab for drug addiction. We tell ourselves we're doing it because the tiny number of people who do benefit deserve a chance, but a rational health bureaucrat who wants to save money might not see it that way. Does all this add up to half? I'm not sure. But I think we can work on cutting back on this stuff without saying things like, maybe medicine is just about signaling, or how do we know if any of it works? Or, you can't trust clinical trials because they're all biased, and that it very, very much matters which parts of medicine we cut. Something like this has to be true, because e.g. Britain spends only half as much per person as the US on healthcare, and Brits have approximately as good health outcomes. This isn't because medicine, in the sense of specific treatments for specific diseases, works any better or worse in Britain. It's for the same reasons that colleges have ballooned in cost without educating people much better. It wouldn't surprise me if expensive insurance doesn't have much marginal mortality benefit over cheap insurance, although it might still be worth it on a personal level because it gets you faster care, kinder doctors, fancier hospital rooms, etc. I don't think the insurance studies tell us anything one way or the other here, and I have no confidence that the things that skeptics think they cast doubt upon are the things we should really be doubting. Second response to Alexander on Medicine by Robin Hanson, APR 30th, 2024. Scott Alexander has responded to my response to his critique of my position on medical effectiveness. On the U.S. taxpayer experiment, where I pointed out a big selection bias re the age range, he's ready to set it aside. I'm not sure what's going on here. I think my case is still strong if we stick with the lower treatment effect or ignore Golden entirely. On the Karnataka experiment, Scott thinks it unfair of me not to point out that he agrees that they saw a medical utilization effect, but only when spillovers were taken into account. However, I don't see why that matters. My point is that they saw large, 74% to 400% effects on hospital utilization among 52,000 subjects over 3.5 VARs, but didn't see overall health effects. I don't see how this study has too low power. But Scott's main point, and thus the one I will focus on here, is that he isn't alone in misunderstanding me, and maybe I'm not being very coherent. I guess I must be misrepresenting him, and I apologize, but I can't figure out how these claims fit together coherently with what he said in the past. So I'll lay out my thoughts on why that is, and he can decide if this is worth another post where he clarifies his position. The marginal unit of healthcare doesn't come clearly marked. If we want to cut the marginal unit of healthcare, for example, following Robin's recommendation to cut healthcare in half, we need to cut specific things. If you would otherwise get 10 treatments in a year, you need to cut out 5 if you want to have healthcare like Robin suggests. Which 5? You could make the decision centrally. The medical establishment decides some interventions are less valuable than others, and insurance stops covering those, or in a decentralized free market way. Customers get less insurance, increasing the cost of medical care and causing them to make harder trade-offs about when to get it. But somebody has to make this decision at some point. On what basis do they make it? How do we have medical care? In his Cato Unbound article, I interpret him as saying it didn't matter how you did it, because most any way to implement such a cut would likely give big gains. But immediately after those quoted words, I say, the obvious first place to cut would be our government and corporate subsidies for medicine, including direct payments, tax exemptions, and regulatory requirements. One could consider taxing medicine, limiting it by law, or nationalizing the industry and using agency budgets to limit spending. At least you can change your own medical behavior. If you would not pay for medicine out of your own pocket, then don't bother to go when others offer to pay. The Rand experiment strongly suggests that on average such medicine is as likely to hurt as to help. A few paragraphs before these words, I explain my general logic. Taken at face value, our inability to see much health impact from the disturbances we have observed suggests that such disturbances increase or decrease helpful and harmful medicine in roughly equal amounts. This in turn suggests that if we were to reduce medical spending via a disturbance similar in character to the types of disturbances we have observed, such a spending reduction would also reduce helpful and harmful medicine in roughly equal amounts. While I feel this quote is pretty clear, I also agree with Scott that he isn't the only person to misunderstand me. So let me try again. Every study on the marginal effect of medicine has some way it operationalizes marginal medicine for the purpose of that study. In geographic variation studies, it is the medicine done in places that spend more on medicine, but not in places that spend less. For studies that compare large to small hospitals, it is the treatments done in large but not small hospitals. For experiments that vary the price of medicine or insurance, it is the medicine chosen by subjects who faced lower prices, but not chosen by those who faced higher prices. I remember at some point also suggesting using treatments with a lower Cochrane review rating. My key point was and is that each of these operationalized definitions of marginal medicine offers a concrete way to avoid marginal medicine. As an individual considering various possible treatments, here are 5 ways. Ask about a treatment's Cochrane review rating. Ask if a treatment is done in low-spending geographic regions. Ask if treatments are done in small hospitals. Ask your doctor how strongly they recommend a particular treatment. Decline if recommendation is weak. I've done this. Ask yourself and associates if you would be willing to pay for them out of your own pocket if insurance did not cover them. Maybe even better to ask several of these questions and average their answers. As a wonk considering various possible policies, you can also consider regulating or subsidizing taxing based on these indicators. Or consider policies that make more patients face higher personal prices for treatment. When I said Most any way to implement such a cut, I had in mind these sort of options. Most any should help, though my favorite option is still creating agents who face strong direct incentives. Scott's offered trilemma, I pick number 3, though the consensus med position doesn't identify enough marginal med to cut med in half, and I don't claim non-marginal med works well. Monkey Trap is not letting go of marginal med, as some of it must help.